Hello, this is Michael Altos, and we are finishing up our discussion of the allergic response from Bearish Chapter 12. This is video part 4. I'd like to finish this discussion with a little bit of analysis of angioedema. There's a lot of confusion about angioedema, and I've compiled some information here. Angioedema is swelling of the deep dermis, subcutaneous, or submucosal tissue due to vascular leakage, and it can occur most commonly in the lips, the eyes, or the face, but it can also occur in hands or feet, or even respiratory or GI mucosa. Our biggest concern, of course, is angioedema of the airway, especially laryngeal swelling, which can be life-threatening. Here are some examples of angioedema of the uvula, of one half the face, including the lip, the face, and the eye. A more pronounced lip angioedema, and here's some angioedema of the hand. I like to categorize angioedema into a few different etiologies. Patients can have hereditary angioedema, which is a congenital syndrome due to a deficiency of C1 esterase inhibitor. Patients can have acquired angioedema, which is rare, due to some sort of consumption of their C1 esterase inhibitor. And there are two subtypes. There's acquired angioedema 1, which is a B-cell lymphoproliferative disorder, and acquired angioedema 2, which is an autoantibody to the C1 esterase inhibitor. Patients may have histamine-mediated angioedema. This is what we think of when we talk about an anaphylactic reaction. And finally, patients can have ACE inhibitor-associated angioedema, which is something you may be called emergently to help manage an airway in the ICU or in the emergency department. What triggers angioedema? Well, in patients who are susceptible, for instance, patients with hereditary angioedema, all sorts of stressors can trigger angioedema. Menstruation, trauma, infection, stress, oral contraceptives. Certainly airway trauma can do it, something as simple as dental work or even suctioning, and certainly instrumentation of the airway. And in patients with hereditary angioedema, there are no specific anesthetic drugs that are contraindicated. Compare this with patients who have ACE inhibitor-associated angioedema, which is the leading cause of drug-induced angioedema. It usually occurs within 72 hours of starting the drug, but it has also occurred weeks or even years after initiation of therapy. The mechanism is thought to be due to elevated levels of bradykinin, which is normally inactivated by angioconverting enzyme, ACE, and this leads to vasodilation and plasma extravasation. Patients at greatest risk for ACE inhibitor-associated angioedema are patients of African descent, transplant patients, and actually patients who have hereditary angioedema or acquired angioedema. Usually, with supportive care, this angioedema resolves spontaneously in about 72 hours. How do we prevent angioedema? Well, patients who are known to have angioedema can receive prophylactic treatment. Androgens, such as danazol, can be used in patients with hereditary or acquired angioedema, but not acquired angioedema type 2. Antifibrinolytic drugs, like tranexamic acid and aminocaproic acid, have been used. The best treatment would be to restore the patient's C1 esterase inhibitor, and purified C1-INH is available in the brand names Cinryze and Berinert. In the absence of these specialized drugs, 2 units of FFP can be given prior to airway manipulation, and this will restore the levels of C1 esterase inhibitor in the plasma. What do we do when presented with a patient who has acute angioedema? Well, it depends a lot on what the patient's underlying pathophysiology is. If we don't know, purified C1 esterase inhibitor is probably the best treatment for all patients, but this very expensive therapy is not always quickly available. There are other specialized drugs like kallikrein inhibitors, bradykinin receptor antagonists, and they may be helpful. Antihistamines and epinephrine often will have no response. Now, the exception would be a patient who's having an anaphylactic reaction. In that case, these drugs may be very helpful. H2 blockers may also be helpful because we note that 15% of the H2 receptors are in the skin. And so an H2 blocker may help with this extravasation and subdermal swelling. Often your best treatment will be FFP. Bear in mind that patients who have hereditary angioedema may have an exacerbation because FFP will increase their complement levels. But in the absence of other treatments, it's probably reasonable to try. And it's certainly effective for patients with ACE inhibitor-associated angioedema because it provides kinase 2, which is angiotensin-converting enzyme. And since these patients are on an angiotensin-converting enzyme inhibitor, restoring that enzyme is thought to be an effective treatment. Patients may require tracheal intubation or even tracheotomy, bearing in mind, of course, that the process of securing the airway may be difficult. But remember that even a tracheotomy may be insufficient if swelling is severe, and patients can have subglottic angioedema as well. That's it for this video. If you have any questions, please let me know.